So this session is going to be on the functional mobility assessment and pretty much updates that we've had since previous presentations. Just a show of hands, how many of you are not familiar with the FMA? Not familiar. Like, meaning I got to spend 10 minutes explaining it. Okay. I'm going to do a little bit of explanation, but I think people get the general idea of it. Just as points of disclosure, yeah, we all have to disclose. I am one of the developers of the tool, and it has been licensed to VGM, and the university does receive a royalty for that. Other people on my team, including Rich, Andy Septano, and Vince, we are on a commercially supported research agreement with VGM to receive the data and do analyses on it. Greg, Kayla, Ron, others also work for VGM, which is involved in the sale or related to the sales of medical goods. So the learning objectives today are going to be, real quickly, is just to be familiar with the TED items of the FMA, know at least 5 of the outcomes that we've done on the analysis, and describe at least 3 analyses of the data. So the FMA, Uniform Data Set Registry, is something that we've developed over the FMA tool itself has been developed over the last 20 years or so. The uniform data set associated with it is something relatively new, and I'm just going to give Greg a moment here to say a few things coming from the perspective of the commercial entity that's collaborating with us on this project.
Thanks, Mark. We have done some commercial projects with the University of Pittsburgh with education in the past, and obviously any of you that are in the private sector understand that working with universities is
painful,
frustrating sometimes, but as we have developed the relationship and with some of Mark's capabilities and the universities, when we've developed a very good partnership and opportunity for you folks that are in the business to be able to access this tool, and we can commercialize it over time. And with that relationship that we built, it's become much easier to do business with the university. They do their expertise, we do our expertise. They do the research, they do the data analysis. We, with Kayla, who's sitting in the audience, have developed a database. We have high levels of security, which are required by any university that you do business with. Some of those hurdles are not any easier to get over because of our data and information security levels that are in the country at this time all over the world. So we do have a lot of those things to follow guidelines, but I have to say that the university has been very respectful and very understanding of what we have to do to make a tool utilizable in the marketplace. And VGM has been very pleased with some of the results, and the data that we're collecting now is, as Mark can explain, that has been very good, and we're getting quite a bit more data as we move forward.
Great, thanks, Greg. So with that, I'll just add that the university, we're responsible for the scientific end of this, and that is making sure that data is valid, that it's legitimate, and our standards for analyzing this data is exactly the same as it would be if it was federally funded by NIH or NSF, probably scrutinized even a little bit more, just to make sure that everything is above board. So the importance of what we're doing, the history behind this is I have a very long tenure doing some outcomes and research. I'm still a clinician at least a day a week or so, and have other responsibilities at the university. But I envisioned this project back when I was in graduate school, and those of you that heard Ken Audenbacher speak this morning, he was one that got me started in this venture, and then in 1994, going to the Vancouver ISS for the first time and hearing Jane Fontaine talk about outcomes is really where this got started. So it was fun to hear her speak today and give the same presentation that was given 23 years ago, and you ask yourself, you know, have we changed, have things changed in that amount of time? And to some degree, yes, but to the same degree is still the same issues of why we need to do this. Outcome measures is going to be pretty much everything about how our existence is going to be sustained over time, and developing a tool that has consistency and uniformity is what the challenge has been. So the functional ability assessment is basically a consumer-centered questionnaire, simply put, a customer satisfaction survey that's highly validated, asking questions based on items or variables that people who use mobility devices have identified as being important to them. So it's gone through a systematic development process. It's gone through test, retest, validation, cross-validation, to the point where we're fairly certain that the information that it's yielding is pretty accurate, within accepted standards of scientific rigor. Drawbacks to it is that it is self-report, and people will, in the scientific community, question whether self-report tools are as valid as, say, observational tools. And there's some validity to asking that question. The point I try to get across is that if we use observational tools as our outcomes, we have to be able to see what our consumers are doing after they get an intervention. If they're not coming back to see us, we can't make an observation. So therefore, a questionnaire is probably the best option. In the spirit of current healthcare reform, patient-centered outcomes have been identified as having the most validity. And so a patient-centered outcome is no different than a customer satisfaction survey. So if your customers look good, that's one thing. But if they tell you they feel good, that's probably even more important than whether or not they look good. And that's really the difference between an observational tool and a self-report tool. So that's really the background of the FMA and why we've done it. I'm going to give you a little bit about how it's scored and what it's done. There's 10 items, and it's on a scale of 1 to 6, 6 being completely agree with the statement, 1 completely disagree with the statement, and then lots of stuff in between. You can get a total score out of 60, and we'll share some of the data with you to show you what we feel is meaningful, what are clinically meaningful differences in scores from one time to another time. The predecessor to the tool was called the Functioning Every Day with the Wheelchair. I'm sure some of you heard about that tool. There's quite a few publications on it. The reason we changed it to the FMA is the way the questions were termed, like my current wheelchair allows me to get around indoors, or my current wheelchair allows me to perform personal care tasks. That question's not valid when someone comes to clinic and doesn't have a wheelchair. So it's very difficult to get an accurate baseline score. We see lots of people coming in with canes, crutches, walkers, no mobility devices. Interestingly, just recently, another subsidiary of VGM called Orthotics Prosthetics Group of America has looked at what Greg's doing in the U.S. rehab side of the business and saying that we need an outcome measure for O&P. So my understanding is that orthotics and prosthetics now is required to have an outcome measure associated with their treatment plans, and if they don't, they get paid less. Is that correct, Greg?
Yes.
Yeah, so if we look at what's happening to them, it's only a matter of time before the same rules are going to apply to us. One really bad thing about being in the wheelchair sector is no one cares about us. One really good thing about being in the wheelchair sector is no one cares about us. So we're under the radar. So you got to look at it both ways. But when we look at what's happening in other areas of healthcare service delivery, we know that at some point that's gonna come upon us. So if that's a motivation to get people to want to measure outcomes, I don't know what else would be. So the items of the FMA are just 10 questions across these 10 domains, ranging everything from how satisfied are you with your daily routine, your comfort needs, your health needs, your ability to operate your device, reach for things, transfer, do personal care tasks, get around indoors, get around outdoors, and use transportation resources. So this is really like the top 10 items or things that people with disabilities have told us that they need to perform. Scoring, like I said, is a scale of 1 to 6. We can translate or transform some of these scores into percentages. We haven't done that a whole lot yet. That's something we're looking at. But basically, this is categorical data at this time. So there's certain regulations or rules, I guess, related to statistical analysis of how we do it. The uniform data set, like I said, was something that evolved in the last couple of years. So just getting a score, a satisfaction score, is one thing. Yes, we know they're improving in their self-reported ability to do mobility-related activities of daily living, but what are some of the other things that are really important to know about what's happening to people over time? So just improved satisfaction is one thing, but there's other things that have to be looked at. And a uniform data set is basically a common set of variables that we all measure and measure it in a consistent way, so that when we're sharing data, pooling data, we're all sharing the same information, and less time has to be spent trying to clean the data and get it all to match up. It's, again, measured across all settings, and is maintained and managed in a central database, or what we often call the registry. So it's the FMA registry. So when we get into initial assessment, and again, this evolved through sort of trial and error as we were getting data from people, and we've been getting data from people for many, many years, long before we started working with VGM and US Rehab. But once we really started putting this out in the field and talking to the stakeholders that are collecting data or care about what the data says, there's more things that we had to come up with. So the common ones that we've been collecting for a while is year of birth, dates of service, primary diagnosis, whether or not they have pressure sores, how often do they fall, have you been readmitted to the hospital in the last 3 months, what type of transportation are you using, getting uniform data on what types of equipment are they using at different times. So it's cane, crutch, walker. In the US here we use power chairs, come in 4 groups, 1, 2, 3, and 4. Manual wheelchairs, we've kept it in the K code system where everything from K1 depot chair to K5 ultralight, and then heavy duty custom chairs. We'd like to collect everything about people, but understand that a uniform data set also has to be a minimum data set, because it's already an onerous task to collect data that if we ask for too much, then people definitely won't do it. So it's, like I said, it's been a fun challenge over the years to get people to want to measure outcomes. And I think now that we're starting to show some of these results, people are getting more motivated to do it. Once a person gets a device, so we collect an FMA score along with the uniform data set at the time of initial evaluation. We've modified some of our workflow templates in our electronic health record system to ask these questions so that they're right there when the therapist is working with the consumer. Some of the suppliers that are involved in this project, like the VGM members, some of them are actually also collecting, or instead of us collecting it, they're collecting the uniform data and taking it back to their place of business and getting it into their electronic record-keeping system. So there's a lot we can talk about the strategies behind doing that. I'll leave it to Greg, and especially Kayla, who's involved in that part of the project, to share some strategies when we get through this data presentation. We've also got other people here, like Carmen's been doing this at Ohio State University. He's going to share some of the data he's collected and what some of that outcome is showing. So kind of like organically, we're creating this project. Different people are using it. The reason we had gone with VGM is because we knew that we had to find a group of people that would be motivated to start collecting a lot of data and collecting it fairly quickly. Some of the pilot studies we had done over the years were good learning experiences, but didn't yield high samples. We got a lot of time 1 data, but we got almost little to no time 2 data. Time 1 data is easy to collect because you're there with the client in clinic. Once you deliver a wheelchair, getting back in touch with them to get time 2 is what the challenge is, and that's where VGM and their HomeLink program came in and says, we're already doing follow-ups on people, we can easily collect this information too. Versus us as clinicians, I mean, when I ran the clinic and tried to get my own therapist to measure outcomes at a university hospital, they're like, we're not doing this. I couldn't pay them to do it. I offered them $1 every time they did an outcome measure, still wouldn't do it. Unless it's attached to your payment and reimbursement or some other motivating factor, most people are not going to change their behavior. So that's why working with a commercial partner with the suppliers made sense. The other thing too is everybody knows that I've been trying to professionalize the wheelchair service delivery providers over the years and have said if you want to be treated like a healthcare professional or be part of the health, viewed as a healthcare professional, you have to have your own science. You have to have your own certification and you have to have your own science, and this is your opportunity to contribute to the science. So anyways, back to follow-up, we collect some of the same uniform data as before. We do a follow-up no earlier than 21 days. We want to have at least a 21-day break-in period. It's a validity issue. If you do an FMA score the day of delivery, there's this new threat to validity that we call the Christmas effect. So kids love their toys the first day, go back 21 days later, that toy is somewhere else, not being used. So that's why we want this break-in period. And then again, we're looking at falls, we're looking at pressure sores, we're looking at what kind of equipment they got, and then putting that all into the system. So when you look at outcomes data, a lot of people think it's research. Well, it doesn't necessarily have to be research. It can be research, but if you look at it in three perspectives, this is what Dr. Audenbacher taught me in my first day of research methods. Treatment information is very useful. So if you put a score on a tool or an evaluation that you perform on your patient, you can share that with your patient, and as treatment goes on over time, you can share the change in score. Sort of like with my students. Here's your GPA, here's how you're doing. You're not doing so good. You need to study more. You need to go to the library. You need to stop going out every night. And then end of the semester, we go, hey, your scores are really good now. So the treatment that I prescribed to you worked, or the treatment that you followed through on worked. As a manager, or as the chair of the department, I want to know how all the students are doing in our department. And what are their pooled GPAs? What are the pooled metrics that we want to see? So if you're the director of a rehab clinic or a wheelchair clinic or a hospital, you want to see this data so you can do quality assurance. You can see where there's disparities, where things need to be improved, and so forth. And then the third part of it is the research. So that's where all those scores go to one location in a de-identified registry so that people, investigators, can go in and ask questions, analyze the data, and see what the answer to the question is. So I think that's pretty well known. It's pretty straightforward. So this is where I was saying everybody has to contribute. So if you're in the front line and you want to contribute to outcomes, then collect data and try to get it to a location or a registry that it can be utilized with other data. What's confusing to some of you maybe is that our group that's involved in this, we do all three of these. That's why sometimes I say I have my clinician hat on today. I do administer FMA scores. I do collect uniform data sets in the clinic I work in. I also work with the clinics to do quality assurance, but then I also wear the hat as a researcher where I'm looking at large data to run analyses. So what we'll share right now is just the data that we've collected in the last year and a half or so. We haven't pooled a lot of data yet with existing data because the data sets aren't fully complete. We've made significant modifications to our uniform data set over time. But I think we're at a point now where it's pretty stable. But we do have a lot of time one FMA scores going back to, some of you may remember when we were doing some pilot studies with the National Registry of Rehab Tech Suppliers. We've been doing some of this with the Veterans Administration. So we've got a fairly good idea of what is typical baseline scores and what are typical time two scores. So right now, and just apologize here, the font's small, we have 358 total cases at time one, and then about a third of that we already have time two data on. So just basic demographics as part of the uniform data set. We know height and weight, we know body mass index, so what it's telling us, and we know year of birth. So we got a general idea of the age, height, weight, diagnoses of the people we're serving. We know how long it takes typically from the time of initial evaluation to delivery. So this is really what I call the benchmarking phase of the registry. If we look at just diagnosis, you'll see here that we still have quite a bit of people that are selecting other. And that's not necessarily a good thing, but it's not their fault, it's sort of our fault. Maybe we're not being clear enough on making a commitment to a diagnosis. But we do know that that big piece of the blue pie there, it just says other neuromuscular condition. So that could be anything from multiple sclerosis, ALS, Huntington's, Parkinson's, could be congenital anomalies. But when I'm looking at this, I'm saying, okay, this tells me that about 75% or more of the people we're serving have a fairly complex diagnosis. You know, it's neuromuscular, it tends to be neuromuscular. It's not that cardiopulmonary is not as complex, it's just that these are the people that we're serving. So if I'm reporting to stakeholders or to policymakers, I feel confident in saying the people we're serving are not just your typical people who need scooters. These are people with fairly complicated conditions. They tend to be pretty severely disabled and could be costing us a significant amount of money for services that maybe we can help reduce if we put them in the right equipment and let them stay out of the hospital, participate in their community, get jobs, use public transportation, all of those good things. The other thing we found from the initial data is that about 75% are either Medicare or Medicaid or both. So we've got a fairly complex diagnostic mix here, and we've got a majority on a health insurance policy that is related to CMS. So this is why it's important for us to consider CMS policy and what we do. Now, what we haven't run on this sample yet is where do these people live? We do have the first three letters or the first three numbers of their zip code. My guess would be because there's a high prevalence of Medicare, Medicaid here, maybe it's rural versus urban. Maybe urban areas have more Medicare managed care. Maybe they have more fee-for-service. Who knows for sure? But that's the beauty of collecting large data is we can go back and take a look at what people are getting based on their funding. Are there any disparities? Are there any disparities between zip codes? Are there any disparities between service delivery models? But this is just initially what we know at this point is that 75% fall into that funding category. Male-female is pretty evenly split, so that helps validate the data a little bit. When we look at VGM data specifically at this point for time 1 and time 2, looking at the type of equipment that people are getting, and this is 106 cases, so these are matched time 1, time 2. You're seeing a pretty significant jump in group 3 power chairs. Group 2s are staying about the same, but there's a lot of group 2 power chairs, and you're seeing fewer canes, crutches, walkers, and more of the ambulatory devices. Again, these are just numbers. It's just telling us what people were in and what they tend to shift to. We're also collecting information about what type of accessories are on the chair. So between time 1 and time 2, you're seeing more seat functions, more tilt, more recline, more elevating leg rests, and in this case too, you're starting to see some seat elevators. Versus if you look at no seat functions, which is the blue bar at the far right, that's at time 1. So just about every chair is shifting to a group 3 power chair with seat functions. This doesn't tell you why, it just tells you what you're working with. Another interesting thing is when you look at type of cushion from time 1 to time 2, a significant increase, and when I say significant, I'm not saying statistically, I'm just saying the IOA analysis, which again, Dr. Odenbacher taught me that. I asked him what IOA was. He goes, interocular analysis. So you look at it, if it looks different, maybe it's different. So, but until you do a statistical analysis, you don't know. I also learned that in statistics, 4 sometimes is the same as 3. And I'm like, that doesn't make any sense. And they said, well, that's statistics. Just because this person scored a 3 and that person scored a 4 doesn't mean that they're any different. And that's not what my first grade math teacher taught me, but that's statistics. That's the beauty of it. But so we're seeing a significant increase in skin protection cushions, skin protection positioning cushions, and we're seeing a significant decrease in people not having any cushion or having just a captain seat or just sitting on a sling. So interesting stuff. So then we say, okay, let's go a little bit further. One of the things we're looking at too is maintenance. So at time one, a lot of chairs were being maintained or being repaired is probably the one that's more important. The reason we're interested in looking at this is hopefully in the future, when we have larger data and we looked at people's utilization over time, that maybe if chairs, equipment that's on a routine maintenance program might last longer, might have more utility, more function than those that are not maintained. We looked at how old the chairs were at time one, and if we were to plot this out in a bell, you can see that 5 years is right in the middle, right at the median or the mode. So some chairs are more than 5 years old, some are less than 5 years old. It's interesting that there's a high number of devices here that were replaced at less than 1 year. And the alarming thing about that is why would something be replaced so quickly? Well, it's pretty obvious. It means it wasn't the right device in the first place, which is why it has to be replaced. So ideally, as we trend data over time, is that devices will last. We'll get a better idea of how long a device should last. The 5-year rule sounds reasonable as sort of a guide, but we all know, those of us in practice, that some chairs last 7 years, some chairs last 3 months, depending on circumstances, use, heavy use, environment. But we have to have large data to tell us or help us predict how long a chair should last based on what circumstances. So ideally, all we're doing here too, from a business point of view, is this is called customer profiling. Okay, de-identify data to predict what customers are going to use under what circumstances and what's going to work best for them based on those circumstances. So that we're not just trying to talk till we're blue in the face about why someone needs a wheelchair or a certain type of wheelchair. We have data to support why that specific device is going to be the most useful given what this current situation is. It sort of takes some of the guesswork out of it. It just helps to better explain what we're doing. So here's just straight FMA scores on the data set here. I think it's 135, which is a fairly good size sample if you're just looking at global change in function. But we'd really like to see that get up to about 10,000. I'm not convinced that these scores are going to change much between this size of a population versus 10,000, because this is starting to level off with the other few hundred sets of data we have. We know that when people are coming in for a new device at time one, just see this here. At time one, their scores tend to be somewhere between a 3 and a 4, which is really putting them at midpoint, even though we didn't want a midpoint to our tool. If you have a 5-point scale and 3 is your midpoint, guess what people pick? 3. If you make it an even number, you're getting them to commit to whether they like or don't like something. So what we're seeing here is about 3.5, so somewhere between somewhat agree, somewhat disagree, tends to be the trend. At time 2, we're seeing that there's somewhere between mostly agree and completely agree. We're not seeing any flooring or ceiling effects here, which is good, but we know that like a 2-point jump seems to be the norm for the cases that we're seeing. This was an interesting analysis that we decided to do. This is sort of the control group study, the serendipitous control group, because we don't really have a control group in this study. But what we do collect at time 1 only, when someone's coming in for the first time, or maybe it's a repeat customer from 5 years ago or many years ago and you provided them with a device, we do ask if the device was provided by an assistive technology professional, a RESNA certified ATP. And on the cases where we've got that information only at time 1, the people who had an ATP involved score much higher than those that didn't have an ATP involved. So if you're looking for some evidence to explain why working with an ATP is a good thing, this data pretty much shows that if you work with an ATP, you're probably going to have a better outcome as far as your satisfaction with mobility-related activities of daily living. Now, we could drill this down further. What we haven't looked at here is what type of equipment do the blue bars have versus the red bars. I could probably tell you clinically, and I know from using the tool myself in my own practice, I've been at the same practice for 21 years now, so I'm seeing people getting their third, fourth, fifth, 10th wheelchair. And if you did a good job 5 years ago, your new FMA score is going to be pretty high versus people that are coming in, say, in a K1 wheelchair that was prescribed by a primary care physician, delivered by some pharmacy down the street. Nothing against them, they're just not in the wheelchair business. The score is going to be pretty low, and that's probably what these red bars are. So that's just an example of things that we can start to look at. When we start looking at the other factors of our UDS, we have the social participation factors, and that is, how many times a week do you, leaving your house? And we're noticing here, this is the employment one. Yeah, the red bar is down a little bit as far as unemployment, but again, I don't think this is soon enough to know whether there's any difference. That's why we want to track people not just 21 days after delivery, but at 30 days, 90 days, 180 days, and then getting annual FMA scores on them to see if that changes. So this one here is the transportation item. What type of transportation resources are you using? What we're hoping to show over time is that when people have good equipment, they are more likely to have access to transportation. They're more willing to use public transportation, they're more willing to use access, or they're more willing to use transportation methods that tend to be less of a drain on resources. We don't know yet for sure, but it's something that we're going to follow over time. And that also helps us when we compare this data to, say, VA data, for instance. Transportation actually is showing to be a little bit better in our VA data versus our non-VA data. Daily device use, like how many hours per day. So what we're implying here is that if you have a good piece of equipment and it's comfortable for you and it meets your needs, you're going to use it for more hours per day, which we could then translate to say they have better participation. And this is interesting that at time 2, just in this sample of 41 people, that 13 hours plus has gone up significantly. So that means that the equipment must be doing something that they like, that they're using it more frequently. This is the next item, which is on living situation. Again, not much change in a short period of time, but again, what we're hoping is that if people are provided with better fitted equipment, they're less likely to live in a nursing home or in a more restrictive level of care, that they're moving from restrictive care to community-based living. And that's kind of a trend everywhere, especially in the accountable care organizations, wanting people to be out of the hospital in the community living. It's not only good for them and their quality of life, it's actually cheaper. So it's where people want to be, and it costs less. This is a question asking how many times a week you leave the home other than for medical appointments. It hasn't really changed in this first time to assessment. It actually looks like people are leaving their house less, which I have to question, is this because they have a new chair and they're afraid to take it outside and get it dirty? I don't know. Maybe a lot of this data was collected in January in Buffalo, New York. I don't know. But over time and with more data, we can see what it's doing. Some of the secondary analyses, too, that we've done on the data set is how many times have you fallen in the last 3 months? Again, it's fairly shortly after the new chair, but the data is showing that there's a lot less falls. And now, is that just by coincidence? We don't know yet, but as we get more data, we can show that. Clinically, I would agree with this, but again, clinically doesn't count until you've done the data analysis on it. And then the other one is looking at pressure sores, skin breakdown on weight-bearing surfaces that would be associated with a seating system. Again, we're seeing a reported decrease in pressure sores. So when you look at using your chair for more hours per day, fewer falls and fewer pressure sores, now if that were to be true, which we have no reason to believe it's not true, and then you go back to the data that I showed you at the beginning, 75% have a neuromuscular condition. They're tending to transition to a higher quality device that would match with that diagnostic category. We're seeing more seat functions being utilized. We're seeing people using their devices for longer periods of time throughout the day. We're finding that they fall less frequently and there are fewer pressure sores. Again, we're gone from no cushions or low-end cushions to skin protection cushions. So sort of like the next step of a large data analysis is to say, well, what is the cost of this intervention? So group 3 power chair, multiple seat functions, skin protection cushion, I don't know, someone throw out a number, 20,000, 30,000, somewhere around there. So if we look at the cost of a pressure sore, now, yes, there are varying degrees of pressure sores. Sometimes you seek medical intervention. Sometimes you just let them heal on their own. Sometimes people fall and don't tell anybody, which is apparently most of the time. Sometimes, including myself, sometimes you have to seek medical attention. So when you look at that investment in $30,000, for instance, and now let's say it lasts 5 years over time. Let's say we reduced this specific case like 2 pressure sores and 3 falls. Did we make out? That we don't know yet. There's models out there, there's health economists that have looked at it and said, yeah, for every dollar you spend on durable medical equipment, Medicare saves $4. And those models make sense, but we still have a little more work to do to show that this is actually what's happening. So, let me just skip ahead here. At this point, I then can, if anybody has any questions, actually it would be a great time for questions because I'm going to transition over to Carmen sharing his Ohio State data.
You have one question, Mark?
Yeah, go ahead. Do we need a microphone?
Yes,
Yeah.
Go ahead. Nope. We'd like to get it as soon as possible from a data acquisition perspective, but quite honestly, most of the time twos we're getting at about, 60 days on average? Right.
That's usually because 21 days we can't get a hold of them, you call multiple times. You just don't want it before that. Some FMA scores I have time 1, date of delivery of their, or time 1, date of evaluation, and my time 2 is 5 years later when I see them again. And I look at their scores from 5 years ago. So there's really no rule. Ideally, what we want to get into is the habit of having some mechanism to track people over time, not just from a research perspective, it's called just from a good practice perspective, especially as clinicians. When I ask people, how do you follow up with your patients? I don't. Well, then how do you know they're having a problem or it's working? We don't. We just wait for them to come back. Well, people only come back when there's a problem, and maybe by that time, you could have done something preventative. So it's just a matter of tracking people, but there's no, it's an independent measure. It's like a bathroom scale. You can take your weight, take your blood pressure anytime you want.
We've built the database to be able to track and identify those date time frames. Time 1, basically taken at initial eval. Everybody in here that's a provider knows that you can, from initial eval to delivery of equipment, on average, from the last survey we took with our members, was about 95 days. So you're not going to get the chair delivered for close to 95 days on average, and then we're waiting 21 days after that. So it can be some time that and a bit of water that runs under the bridge before you get that. Now, once we get our time 2 data, then the clock starts again. Now the clock becomes much more reasonable in that we know when we do the next. We do 5 contacts in the first year. VGM and US Rehab have developed the resources to do that for our members who are participating. We've just opened it up for our full membership in the last 3 to 5 months. We were doing it with a very select group of folks to begin with. That's why we've collected a lot more data recently. So one point I was going to make too is Mark talked about transportation. Transportation and outdoor use. Obviously, you saw the numbers for Medicare. Transportation and outdoor use is not viewed as anything that's involved in getting your equipment through Medicare, which is a travesty. We all know that, and we're fighting for the separate benefit category in Washington and other things. But as we go over time, we'll be able to prove that. I didn't say that, Mark. Not prove. Statistically, a statistical probability that it is likely that if you can utilize your chair outside and with your transportation to get to the doctor, to get your medicine, that you will have more healthy days. You will have a lower lifetime cost. Right now, we've done quite a bit of research and looked at different things out there that's already there. Nothing that I've sat down and done research, but for a C3 to C4 patient, it's about a $4.5 million cost, lifetime cost now, average. The first year is $1.2 million. So anything we can do in that first year to prevent wounds, to prevent readmissions, we are going to be able to help reduce that lifetime cost. 25% of their full lifetime cost is that first year. So with us contacting patients and having the interaction and understanding what may be changing in their environment, in their life, can help. I think that's where we've tried to stay on top of those things, but sorry, did you have a question?
I think you answered it, both the contact rate, contact rate.
Yes, and the other thing that we have done because of the measure, we had scores, you saw the scores, Mark is much more adherent to statistical analysis. I was just happy to see that he said that 3 was sometimes the same as 4, because now I know that my 2.5 GPA in college could be a 3.5. So
Depending on college.
Yes, exactly. So, but what we've seen is that we can when we have a drop in score that's more than a 10% drop in score at any time in our analysis, then we are looking at the 10 questions. If the drop in the score was typically apparent from question 10, which has to do with transportation, maybe they lost their mode of transportation and it's a local county issue because now they don't have a bus system that can take someone to the doctor. That we can't, as an ATP or as a clinician, we have a harder time fixing something like that. Although with our political action committees and People for Quality Care, other ones that we have, United Spinal, we can report those things and help that patient, which that gives us the opportunity to continue to give those patients that forward opportunity. But if it happens to be something that we can change, i.e. one instance that we had that Mark talks about once in a while is that we found a patient that their foot was falling off of a foot plate. So we immediately identified that. We immediately call the provider. They just happened to have somebody in the area that day. I mean, thank God. So they dropped by, put a new heel loop on, did some Velcro, and problem solved. Mark knows more than I about what can happen with that, but if you run over the foot, have to have surgery, what's the cost? So
We all have that client, right, with the
diabetic, let's hang on.
The diabetic client with no sensation in their foot, and their foot falls off the foot plate, and the caster runs it over, and they get a sore. That's what was happening here, but it was because of this follow-up process. That's just an example of how you can be preventative.
Change in medical condition. I didn't see that there was a question asking, have you had a recent change in medical condition? And I thought that addressed one of your drafts.
So the UDS, the Uniform Data Set, we ask the same questions every time. There are roughly, and Kayla's the expert behind that because she's worked with our database management folks and the questions with the University of Pittsburgh, but I think we have, Kayla, 38 to 40 questions on the UDS. Those are asking those types of questions, disease, condition,
The gentleman's
change.
asking a good question. We're not asking if there's a change.
Oh,
We're confirming the diagnosis is the same, but you bring up
Correct.
a very good point. That's why we like sharing this, because that's oftentimes one of the first things a healthcare professional is going to ask you in your appointment, has anything changed? Now, we are asking if you've been hospitalized in the last 3 months, and if so, is it related to a mobility issue? Yeah.
one of the things we've done, though, is obviously REACH is one of the questions. So we have in the actual FMA items or section where you can put notes in. So if you are working with a funding source that doesn't allow funding for, i.e. a seat elevator, and you get burned on your stove within 2 weeks of getting your brand new chair because you were unable to elevate above the stove to get the salt and pepper like you did before, then we are seeing those conditions and we're trying to notate that. So we're asking a lot of questions on the front end to find out who the payer source is, what's going on there. We think that'll be very valuable for helping to show that ATPs do bring a lot to the table for patients as well as our clinical folks who want to make sure that the patient's able to live in the current environment that they live in. All of the original beta testing and original folks are U.S. rehab members who we hand-selected that I knew their ATPs personally, that Mark knew their ATPs. Most of them provided data to the program when NARTS was there. They understood it. And so a lot of the data that we have is top-notch ATPs. Right. I'm not saying that there are any not top-notch ATPs, right. But some ATPs work in the pediatric world, some work in the adult world, some work specifically with disease states, MS, other types of disease states in specific areas. So we tried to choose areas of the geographic population that weren't consistent, that weren't in one area. So we originally picked from some select areas, and that's how we did it.
So they are the early adopters, and yes, that could potentially bias these initial results because they might be the best of the best. So. Right. Right. We're not looking at that yet. Again, we have to be minimum. If we ask too much information, people won't provide it to us. But those are valid, very valid things. That's probably something you can do as a business owner when you get your results back. We're treating this very similar to the functional independence measure. You will get a report back that says, here's your scores, and here's your scores compared to national averages. We're not going to compare you to your competitor down the street, but you'll be able to look at the data, and you'll be able to trace the data back to actual patients, and you can start to see, are there differences between getting discharged from this hospital versus that rehab center versus maybe some other factors.
One of the other things that we've built into the system is an educational component. Yeah. We're tracking ATPs, If you have an ATP that falls below the national average curve on a specific disease state, we took the top 5 disease states. We just got done funding a educational creation of those top 5 disease states from beginning to end of the disease, and we had physician, nurses, PTs, OTs at the PhD level write the education for us, and it will be on the outcomes website that we have that's called VGM Outcomes, and it has orthotics and prosthetics outcomes and rehab outcomes. And once an ATP is identified as possibly below the national average, our biggest focus is to create an elevation in our industry to help them get better at what they might not be good at. We also have identified ATPs that have given us data that are very, very good at specific disease states, and we will have interaction from them to be able to communicate with someone who doesn't understand possibly the disease state as well. Or maybe there's tricks. Jerry, who introduced us here, knows the industry very well. He knows tricks of the trade that can help patients. It's that kind of knowledge base that's going to help us continue this industry and help us continue to help patients over time.
We got to move on because Carmen's.
Did you ask who did the delivery? Was it a technician or was it the ATP?
We're not asking that now, but we're very interested in knowing. We're not. Yep.
Yes.
We're not
we,
asking
we
that
do
now,
know that.
but we have that has come up because we're having an issue in our clinic with that.
I'm sorry. I think we're going to let
Yep,
Carmen
go
take
ahead,
over.
Carmen.
Thank you.
All right, so I'm gonna shift gears here and talk about what we're doing for quality assurance.
Is your mic on?
It's
Screen?
green. Is this mic working?
This one's working. Here, just throw that one on the table. I'll just steal Greg's microphone if I need to talk.
All right, that one's working, great. So I'm gonna provide a different perspective. I'm a rehabilitation engineer, so one of the things the example that I always give with our quality assurance programs, in general, is the idea of cruise control on your car. From an engineering perspective, we call that a closed loop feedback system. You have to know what's going on in your system within that black box, or else the cruise control won't work in your car. You'll just keep on accelerating until that police officer pulls you over. Well, the same thing goes on. We had the same idea when we started the AT program, the AT Center at Ohio State University. So this goes back to, I came on in 2009. I've worked with Teresa Berner since that point in putting this program together, and I've really taken a focus on the numbers side of things. What do we do? And there was 2 things that we found out early on as we were developing the program. One was that people were coming to us when they had a problem. Well, that's a good thing, but we want to make sure that we capture them before they have a problem. And we thought that the simplest way to do that was really focus on how are people getting their wheelchairs, the service delivery aspect of it. And quite simply, we came up with a database. We have a database that every person that comes into our clinic, it goes into a secure database, and we track what day was their evaluation, and we have a secondary date that we put in there. And if nothing happens with it to that secondary date, which is usually 3 months, we get an exception report. And so that was one way we were able to track that the process was moving along for them. And that was great for that whole evaluation assessment component of it up to the time that the individual's getting the wheelchair. The second part was we wanted to know, are we doing a good job? Are the clinicians that are working in there providing the services that we think they're providing? And really, I got to focus on the multidisciplinary team. We really don't know if it's the clinician. We don't know if it's the supplier that we're working with. We just want to know we are a team working together and that team is providing the services. And so that was the genesis of what we were doing. So the first thing I have to do, in order to do this, it took a lot of people. And I'm trying to give the perspective of if there's other medical centers or other centers that want to do this, this is what it takes. And so I've listed up here, there's 3 students, Julie, Taylor, and Stephanie, that have helped us over the past 6 years, because we started looking at this in 2010, and the data I'm going to provide is from 2012 to 2016. And then a lot of the clinicians that have been involved along the way, a lot of them presenting. And you'll see some of the stuff that I'm talking about is kind of hinting at the service delivery model. It's hinting at the business of running a wheelchair clinic. And so I'm going to put the shout out to Teresa Berner and Tina Rossler talking about that in a presentation later on, and we'll go through those specific things. But in order for this to occur, we have to have a change in culture. And that's really what we've been able to do to get to the point that we have data to report whether or not we're doing a good job or not. And that's simply the only question that we had, was we wanted to prove to ourselves most importantly, but then the nice thing is we can prove to our leadership that the services that we're providing make a difference for the people that come to our clinic. The interesting thing here, so this is just demographics, and the reason I just wanted to know who is coming into the clinic, the interesting thing is that we have that same problem with the other group. The other group is 23%. I think Mark's, the data he reported earlier was around 21%. So that's been an issue for us as well. But then you see the top 4 groups are spinal cord injury, cerebral palsy, stroke, CVA, and MS. So it's a complex group that we're working with in our clinic. The next slide is a representation of how there's a shift. So on the left-hand side is a description at the time of the initial assessment. And we've got numbers in the cane, people who are using a cane crutch walker or a scooter or no mobility device at approximately 25%. Everybody else is using a power wheelchair or manual wheelchair when they first come to us. On the right-hand side, you can see that huge shift to the majority of people, greater than the majority of people are now transitioning to a manual wheelchair, and we see a large increase in power wheelchairs. The 2 things that I'll point out here is, one, you can see our initial values, we had over 800 people participate at baseline. It's a challenge to get that follow-up data. That's been a challenge for us because we're at approximately 148 people at follow-up. The way we did that was we have a paper-based survey. That's the least common denominator in terms of the clients that we work with in our clinic. And so we use a paper-based, we mail it out, and we get it back. But this gives us a snapshot of what's happening in the clinic, and it's not really, from a program side of things, it's really not that surprising, because if somebody's getting a referral to us for a wheelchair evaluation, it's not surprising that fewer people are using a cane crutch or walker when they're leaving, and they're mainly going to scooters, manual wheelchairs, and power wheelchairs. When we start looking at age, we can see we're looking at an older population. The majority of them are between 50 and 80, and that's both true at the initial on the left and the follow-up on the right. So from my standpoint, this is where things get a little interesting. We see that, so on the left-hand side, we have the average FMA score. Now, my scores are actually, on here, our scale is from 0 to 60 because we sum all the scores together, the 10 categories, which each score is a possible score of 6, so you get up to 60. And our average is, across the board, 32.9, and so not surprising to me is that people who are using no device or are using a cane are lower than the average. People who are using power wheelchairs and scooters are above average, and manual wheelchairs right in the middle. This is just what it is. But the next one is the one that from closed, so this is really where that closed loop feedback system, we got to get that information back to us on what is going on. Are we doing a good job? And from our standpoint, we are, because we're going from an average score of 32.9, granted that's across 800 people, so whether we didn't match it up, because this is just quality assurance. We're not doing statistical analysis. We just looked at all 800 people. It was a down and dirty analysis. We're at 32.9. We're going up to 48.3 at the follow-up. And the researchers in the room, I can hear them right now going, well, that could be all the people that are happy with their wheelchairs responding to your, right? I get that part. But this is not at that end of the spectrum. This is at the other end of the spectrum. So for what we're seeing, our service delivery model is working. And the important thing to me is, as we move forward, if we ever see a dip in that follow-up score, it gives me a reason to dig deep. So that's the engineer in me. I want that depth when I need that depth. I don't want to go deep if I don't have to, but if we need to, we will. And so if we start seeing changes, now we've got those baseline values to say, oh, we're seeing this dip. What has changed in our program? Has there been a change in the amount of time the clinicians are spending with the consumers? Have we changed the number of appointments? Instead of doing one appointment, or instead of doing 2 appointments, we're doing 1 appointment. You know, there's all these different variables, but we can start looking at that. But if you don't have that baseline data, you can't do that follow-up data. And then the last slide I have here is just, it's busy, I understand, but it's a matter of breaking out all 10 different categories. And for me, the other thing we'll be watching in the future, do we see any changes? So you can see baseline starts out in between, similar to the data that Mark showed earlier, between 3 and 4, and then at follow-up, it's between 5 and 6. And the thing here is, okay, if we start seeing changes in the future, we can start focusing on individual areas. So my goal today is really not to have you to try to take down this data and apply it to your own situation. My goal really is to say there is a way to do it. It does require a change in culture. It takes a lot of people getting on board, going back to that acknowledgement slide, and trying to figure out a way to really get everybody to say, we want to provide the best services possible. We know we do. We found a way to demonstrate that and to record it, and how do we use that internally? So at that, if there's any questions for me about the service delivery process, or if there were more questions for Mark and Greg, I think we have about 5 minutes left.
Go ahead.
Was that all done at your place? I mean,
So yeah, so the question was all the data that, at this last part, this is just OSU data. There's nothing.
So when they come in the clinic, doctors, therapists, ATP, all that?
All that. So we've only had a physician for 2 years, and this data represents 4 years worth of data. So I guess we could, if we wanted to, go back and to see if there's a difference at that time point. But I quite frankly, I don't care as long as the data looks good. But yeah, so this was all taken here, or all taken at completed at Ohio State.
For follow-up, I know that's a challenge. What are your recommendations? What's worked, what's not working?
Well, I don't know if it's worked, but the way that we got the 148 people was we had a student that sent out at 21 days, would send out a flyer, or not flyer, would send out the form for them to fill out. The nice thing is they filled out that same exact form at baseline, so they're familiar with it. It's not a challenge. Oh, no, we send them their file, yeah. I can't imagine that they're actually remembering what they wrote the first time, but I guess that's always a possibility.
So if we look at other areas of healthcare that have done similar, like I said, this was somewhat modeled after the functional independence measure, which is FIM. The way that works the best is you just have to pay somebody to follow up. Not pay the patient, but you have to hire somebody. You have to hire somebody or have somebody, it's their responsibility within the clinic or business to be following up with patients. Clinicians don't have time to do it, ATPs don't have time to do it. You can mail stuff out, some will return, some won't, but that we kind of knew that going in. And when you look at loss to follow-up, what's acceptable, it's well understood in our field that you're going to lose a lot of people to follow up, as long as you can account for why you can't get a hold of them. Greg?
One of the things that we've done is we have a very mechanized system that we've developed. We identify by flagging patients at the time that their follow-up comes up. We have as much information as we can collect on the front end in our UDS. So we're asking for email address, phone number. We really want to communicate with the patient on telephone time 2, time 3, time 4, time 5. We make at least 2 phone calls at different times during the day before we send out a secondary type of communication. We mail or email information to that patient to contact us because it's time for a follow-up. Once we wait 45 days after that letter has went out or email, and we have no follow-up, we deactivate the patient. Currently, we're running about a 40% rate of contact on the follow-up. We're at time 4, I think. Kayla, do we have any time 4 yet, or is it just a couple time 4s right now? Our fall-off at time 2 is, we get 40%. At time 3, I think it's in the upper 80s, and at time 4, I think we're at 90-some%, meaning that when we contact that person at time 4, we're getting contact with 90% of the people that gave us time 3.
Yep, the question, yeah. I'll repeat it.
It's any kind of transportation.
Okay, so the transfer is, question is also, is it just the household transfers, or is it a car?
Could be any. Personal or public transportation.
They may go to the sidewalk to go to their pharmacy if they live close enough. It's whether they can function in their daily routine.
So
With the public transportation?
I only have 2 cases that did not apply, and that's because they lived in the village, never got in a car, never got on a bus, never used a motorized vehicle. Most people at some point have to. And if they say they don't use it because they can't put it in the trunk, they should score that a 1.
Okay.
It's not, there should really be almost never does not apply. These are 10 items that have been validated based on thousands of goals stated by individuals. 99.9% of the population is going to see all of these 10 items as being relevant to their mobility-related activities of daily living.
Okay, that clears me up. Thank you.
Yeah.
We asked for any mobility device to be done. What we're getting probably is more manual wheelchairs, power, and complex, so standard. But now that we're going into the orthotics and prosthetics arena through our OPGA, I think we'll see more of the other products as well.
But the tool itself is independent of device. People come in with no device, and you can still get an FMA score. We could administer FMA scores on ourselves. Hopefully, we'd all score 60 out of 60, but it's really not dependent on what type of equipment you use. Except we do want to know what type of equipment you are using, even if it is no equipment.
Patricia Van Curler from Spokane, VA. I think this will be fascinating once VA information is in there too. Hopefully it will be supportive information. If See It Elevate, if we're providing them, you're showing huge benefit to either transfers or reach, maybe there'll be some application and crossing funding sources.
Exactly. Go to Vince's paper tomorrow. Yeah.
It does.
I'm asking if, about compliance. So an example would be if they got a tilting space, are they tilting back on a regular basis? Or if they have a row, are they checking it? Is there anything in that that's checking to see if they're compliant with use of the equipment?
We do not have anything at this current time on the UDS for compliance at all.
But This is just baby steps. You all know if you go in the exhibit hall, what's everybody putting on their power chairs now? Internet of Things. So FMA scores are going to become as much a part of the chair itself, how much you tilt, how far you go, where you go, GPS tracking, all of that's coming. If we have no way, currently in a standard power wheelchair, when someone comes in to see me and I ask them, do you tilt? Of course I do. Yeah. Then why are you sliding out of your wheelchair? Or show me how you tilt. Okay, I don't, or I say, you want to stop sliding out of your chair? Here, let me show you how you can tilt, recline your back. Oh, no one showed me how to do that. And it's like, I showed you how to do that 3 months ago. But as we know, in the delivery, nothing, a small percentage cares. But compliance, it's not, we'd love to know that, but again, is how easy is it going to be to collect that information and collect it accurately? We got to wrap it up. Yep, we got to wrap it up.
Do you have a pediatric modification to this scale? And if
We have
not,
a-
are you working on one?
Pediatric, family-centered. Is Delthea in here? Delthea Brown? Is Delthea Beavers? Yeah, Delthea is here. That was her PhD. So we're still in the process of rolling it out. So. Yep. All right. Who's the code guy?
Code guy. Jerry.
Jerry, are you the code guy? And the envelope?
That's why they're not leaving, Jerry. They would have left. They would have left an hour ago.
Before you get the code, thank you for attending. We can answer any other questions, please ask us.